Extract 1. Questions 1 to 12. You hear a doctor talking to a patient. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, I'm having asthma and facing difficulty in walking even 10 steps. My weight is 344 pounds. I have high cholesterol and high blood pressure. I have joint pain, back pain, foot and ankle pain, and swelling on my leg and foot. I have sleep apnea and snoring. Moreover, I am a diabetic patient on medication. I also have hemorrhoids, doctor. I am also pursuing surgical attempts for weight loss and to become active in my life again.
What's your age?
37, doctor.
Okay, do you drink or smoke?
I do smoke, and I have stopped drinking alcohol a year back.
Have you undergone any surgeries earlier?
I underwent orthopedic knee surgery, doctor.
Can you brief me about your family history of diseases?
All my family members have obesity, heart disease, and diabetes, and negative for hypertension and stroke. But I am using Chantix to come off smoking completely.
Okay, tell me about your food habits.
I eat things like bacon, eggs, and cheese, cheeseburgers, fast food.
How many times do you eat in a day?
I eat 4 times a day, 7 in the morning, at noon, 9 p.m., and 2 a.m.
Well, the ideal weight for your age is 184 pounds, and you are weighing 344 pounds. That means 184 pounds in excess. What medications are you taking?
Diovan, Crestor, and Tricor.
Do you have any chest pains or any mild attacks?
No, doctor.
Well, your cranial nerves 2 through 12 are intact. Neck is soft and supple. You have positive wheezing bilaterally. Heart rhythm is normal. Abdomen is soft. You have 1+ pitting edema. I have reviewed your complete test reports. This is a clear case of bariatrics, and you need to go for a laparoscopic Roux-en-Y gastric bypass. The complications include infection, bleeding, pulmonary embolism, deep venous thrombosis, leakage from the gastrojejunal, anastomosis, and possible bowel obstruction. Before we proceed for the surgery, you need to get reports on upper endoscopy, H. pylori testing, thyroid function tests, LFTs, glycosylated hemoglobin, and fasting blood sugar.
Okay, doctor. I would like to proceed with the surgery.
Extract 2 questions 13 to 24.
You will hear part of a consultation between a GP and a patient called Mr. Martin.
For questions 13 to 24, complete the notes with word or a short phrase.
Hello, Mr. Martin. I'm Dr. Hampton.
Hello, nice to meet you.
And you? How can I help you?
Well, I've come about my stomach. I've had problems with it over the years, on and off, but at the moment it seems to be worse again. Mainly kind of just real sore feelings across here.
Okay. When you get the pain, where is it exactly? Can you show me?
Yes, it's here. It's sort of across the upper part of the tummy and down here to the middle of the tummy.
Uh-huh. And how would you describe the pain? Could you put words to it?
It's more sore. I can't say it's a real pain. It's more a sore feeling and like irritation, maybe?
Right. Does it move around or is it always in the same place?
Yeah, I mean, sometimes it always seems to start here in the middle, kind of. I can feel a bit there now, but I've had it more down each side as well, and I didn't know. At one point I wondered whether it was my kidneys or something, or whether it's still the same thing. I don't know.
Okay. And you said it's both sides. Do you mean together or does it sort of flip from one side to the other?
Yeah, not together. It goes from one side to the other.
So it really moves around this pain, doesn't it? Do you get bloated when you get the pain?
Yes, very bloated.
And can you tell me how long this has been happening?
Well, I first had it several years ago. I had it when I was working, and a doctor I went to see said then it was probably irritable bowel. That was 4 years ago.
Right. Was the bloating a part of that too?
Yes.
And did things settle down for a period of time?
Yeah, they settled down when I was watching my diet much more, and when obviously I wasn't as stressed. I'd given up work.
Okay. What about your bowels? Can they be a bit variable?
Yes, very much so.
Could you tell me a bit more about that?
Well, I've always had a bit of a problem with constipation, mainly. But I mean, I'm going just recently going perhaps a couple of days and not really going. And then, like, in the last couple of days, every time I eat, I seem to want to go.
Right. And are you getting loose motions?
It's loose, yes.
Right, okay.
Yeah, I mean, really, nothing has changed. I mean, I drink loads of water, but when I'm constipated, it's really hard and just like, like small brown pieces when I go. And then when it's loose, it's a bit ribbony. I've always had a bit of a ribbony movement.
Yes. Is it true diarrhea or not?
No.
No, okay. Have you passed anything unusual looking? Any blood or slime or anything strange?
No, I haven't.
Haven't passed black motions as far as you know?
No.
When you had the IBS before, what sort of things did you do for it?
I think Dr. Dorsey gave me some Colofac, is it? Or something like that?
Yes, that sounds right. Was that helpful?
Kind of. Because she explained to me about a kind of a spasm thing. But I just kind of watched what I ate again. I mean, it's probably worse if I don't go to the toilet. And so, I try to eat things and, to make sure I do go without taking anything, without any laxatives of any description. And then I know it's probably really old-fashioned, but I take peppermint oil. You know the capsules? And I think they're actually really helpful.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at question 25. You hear a discussion about different types of kidney cancers. Now, read the question.
Hello, doctor. Can you brief me about different types of kidney cancers?
Well, like any other cancer, kidney cancer starts when the normal cells in one or both kidneys mutate and grow aggressively, forming a tumor or mass, which can be benign or malignant. Kidney cancers that have originated elsewhere and metastasized to the kidney are clear cell adenocarcinoma, transitional cell carcinoma from the bladder, renal lymphoma, inverted papilloma carcinosarcoma, teratoma, and carcinoid tumor of the renal pelvis. Renal cell carcinoma is the most common type of kidney cancer that accounts for 80 to 85% of all cases. This develops within the microscopic filtering systems of the kidney, which are the tiny tubes that carry the urine to formation. Transitional cell carcinoma, also known as urothelial carcinoma, usually begins in the area where urine collects before moving to the bladder. Pathologically, this cancer is similar to bladder cancer and is treated like bladder cancer. Kidney sarcoma is a rare form of kidney cancer that is usually treated with surgery and chemotherapy. Sarcomas may be large and usually does not spread. Wilms tumor is a common type of kidney cancer that occurs among children and is treated differently than kidney cancers in adults. Common treatments for Wilms tumors are radiation therapy and chemotherapy. Squamous cell carcinoma, juxtaglomerular cell tumor, or rananoma, Bellini duct carcinoma, mesoblastic nephroma, mixed epithelial stromal tumors, or other types of kidney cancers. Question 26. You hear the discussion between two doctors about types of perforations during endoscopic retrograde cholangiopancreatography. Now, read the question.
Doctor, can you explain the types of perforations during endoscopic retrograde cholangiopancreatography?
Well, although perforation is an unusual complication of endoscopic retrograde cholangiopancreatography, the diseases of the duodenum and common bile duct can increase the risk of perforation during endoscopic retrograde cholangiopancreatography. There are 4 types of perforations during endoscopic retrograde cholangiopancreatography based on etiology and site of perforation. Type 1 is perforation of the lateral or medial duodenal wall caused due to excessive pressure from the endoscope or its acute angulation. Type 2 perforation is periampullary injury, often associated with sphincterotomy or difficulty accessing the biliary tree. Type 3 perforation is injury to the common bile duct or pancreatic duct caused by instrumentation. Type 4 perforation is the presence of retroperitoneal free air with no evidence of actual perforation. This is usually an incidental finding and is of little or no clinical consequence. Question 27. You hear a discussion between two doctors about clinical manifestations of alpha-1 antitrypsin deficiency. Now, read the question. Hello, doctor. What are the clinical manifestations of alpha-1 antitrypsin deficiency?
Well, alpha-1 antitrypsin deficiency is associated with 2 major clinical manifestations. Emphysema, resulting from the loss of the proteolytic protection of the lung by alpha-1 antitrypsin, a toxic loss of function. Other clinical manifestations of alpha-1 antitrypsin deficiency include pancreatitis and an association with cytoplasmic antineutrophil, cytoplasmic antibody positive vasculitis.
Question 28. You hear a discussion between a doctor and a nurse about autoimmune liver disease. Now read the question. Hello, doctor. What are the autoimmune liver disease?
Well, autoimmune hepatitis, primary biliary cirrhosis, and primary sclerosing cholangitis are the three most common forms of autoimmune liver disease. Autoimmune hepatitis is characterized by high levels of serum alanine aminotransferase and aspartate aminotransferase, whereas primary biliary cirrhosis and primary sclerosing cholangitis are associated with predominant elevations of alkaline phosphatase since they are cholestatic disorders. Primary biliary cirrhosis and autoimmune hepatitis are associated with autoantibodies in the serum, such as anti-nuclear antibody, smooth muscle antibody, and anti-mitochondrial antibody. Primary sclerosing cholangitis usually affects the extrahepatic biliary system. Thus, if it is present, abnormalities can be seen on imaging.
Question 29. You hear a discussion about brain chemicals involved in mood regulation. Now read the question. Hello, doctor. What are the brain chemicals involved in mood regulation?
Well, basically there are three molecules, chemically known as monoamines, that are involved in mood regulation. Serotonin has been coined the brain's feel-good chemical. Norepinephrine is another neurotransmitter connected with depression and how alert the feelings are. A low level of norepinephrine is considered to be associated with the brain fog that many people with depression experience, whereas low levels of dopamine in a part of the brain called the substantia nigra associated with Parkinson's disease. But there is much more to dopamine. In the frontal lobes of the brain, it is associated with complex thinking and problem solving. In fact, it is considered that the stimulatory effects of chemicals such as nicotine and cocaine are related to their effects on the dopamine-mediated reward centers in the brain.
Question 30. You hear a discussion about different types of gastric juices. Now read the question.
Hello, doctor. What are the different types of gastric juices?
Well, the food we swallow mixes with gastric juices secreted by special glands in the lining of the stomach. They include the cardiac glands at the top part of the stomach, the oxyntic glands in the main part of the stomach, and the pyloric glands in the antrum or lowest part of the stomach. Therefore, each of the glands contains cells that produce specific components that are called the gastric juices. Neck cells produce bicarbonate and mucus. Parietal cells generate hydrochloric acid. Chief cells produce pepsinogen, and enteroendocrine cells generate various hormones. Hydrochloric acid is a strong acid secreted by the parietal cells, and it lowers the pH level of the stomach to around 2. Hydrochloric acid converts pepsinogen into pepsin and breaks various nutrients apart from the food we eat. It also destroys bacteria that comes along with the food. Gastric lipase is another digestive enzyme made by the chief cells. It helps break down short and medium-chain fats. Amylase is also found in gastric juices, but it isn't made by the stomach. This enzyme comes from saliva and travels along the bolus into the stomach. Amylase breaks down carbohydrates, but doesn't have much time to work on the stomach because the acidity stops it. Intrinsic factor is secreted by the parietal cells and is necessary to absorb vitamin B12. This is essential for healthy nervous system function and blood cell production. Finally, the gastric juices contain water and mucus. The mucus is secreted by the neck cells and helps coat and protect the stomach lining from the acid environment.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Tell me a little bit about the progress in the plant-based movement recently.
There's been tremendous progress, particularly in the health field. At least that's certainly my perspective. So in the States, there's just been a real surge, a real tipping point in terms of the plant-based nutrition movement. There are now entire conferences. There's an international plant-based nutrition healthcare conference. Hundreds of physicians, other medical professionals get together, talk about how they're using this in their practice. I mean, that didn't exist a few years ago. I mean, it's really, really exciting. There's new vegan medical clinics opening up where all the folks on staff are using lifestyle medicine approaches, not just to prevent disease, but to stop and reverse it as well.
Tell me about the main players involved. You've got Nutrition Facts growing, you've got the Physicians Committee doing a lot of work. Who are the main players and what's been achieved specifically in the last few months and last year? What's been the memorable moment for you?
Well, so, a lot of people don't know about Scott Stoll, who started this, PBNHC, this Plantrition project, this plant-based nutrition conference. He's been doing these immersion programs for Whole Foods for a long time now. He has a book coming out.
Okay.
I'm very excited about that. He's just had transformative experiences. He's just a physician in practice. There's people all over who've been doing this in their own little, hometowns. But it's just great to get so many people together, start networking. So there's wonderful resources out now, documentaries. We got a number of documentaries coming up, like The Game Changers and Eat Yourself Alive. And, this is an exciting time to be in the movement. And I think, a lot of it is just there's so much, we're going to get there if only because the healthcare costs are spiraling out of control, right? Climate change. We're just going to be forced to have to take these, safe, simple, side effect-free solutions, cheaper, safer, more effective than conventional medical approaches, because we're talking about the leading killers, right? The leading cause of death. The good news is that the vast majority of premature death and disability is preventable with a plant-based diet and other healthy lifestyle behaviors. We have the power, we have tremendous power over our medical destiny and longevity.
You talk passionately about the benefits of plant-based diet, particularly reversing heart disease. My old boss, he was a professor of epidemiology called Professor Tim Spector. He said he met Dr. Dean Ornish. Dr. Dean Ornish said, the thing with the plant-based movement is you get the sense you're either with them or against them. We're going to talk about that in a minute. But also what he said was there aren't any large randomised control trials. He said, Dr. Dean Ornish, show me the large randomised... Why aren't there any? If we've known about this since Pritikin's day, where's the data, the large randomised control trials?
Well, look, Ornish published his first RCT, randomised control trial, July 1990, in The Lancet, the most prestigious medical journal in the world. There it was, black and white, proving with quantitative angiography that we can reverse heart disease, open up arteries without drugs, without surgery, just a healthy plant-based diet and other lifestyle changes. There it was. Right? So we've known about it for decades, but there it was, published in some of the most prestigious medical journals in the world, The Lancet, JAMA, yet what happened? Nothing. Hundreds of thousands of people continue to die of a reversible, preventable disease.
So it's being ignored.
It's being lost down the rabbit hole and ignored. I said, well, wait a second. If effectively the cure to our number one killer could get lost like that, what else is there in the medical literature that could help my patients, but just didn't have a corporate budget driving its promotion? I made it my life's mission to find out. That's why I started nutritionfacts.org, and that's why I wrote my new book, How Not to Die.
What I find very interesting is you say the system needs to take on board this message, but the whole point of Nutrition Facts was to go round the system. Tell me a little bit about the democratization of information and the role that's played and why that's been good for the movement, I guess.
When I started out ignoring the general public and going straight, trying to train the trainers effectively, going around speaking at all the medical schools in the States to try to, get the next generation of doctors educated. But then I realized that's a slow way about it. We don't have time. People are dying now. I don't need to, for another 10 years for them to kind of slowly take over the medical system. People are dying now. We need to take this directly to the people. And thankfully, thanks to the internet age, we now have this democratization of information. Now everyone has access. Before, the doctors had a monopoly on information about health. And so, big pharma, the food industry, all they had to do was get to the doctors. The tobacco industry, as long as they could get the AMA on board by writing them checks for $10 million, and so they came out opposed to the Surgeon General's report against smoking in 1964. As long as they control the doctors, they control the health message. No longer. Now, people can get to the science directly, educate themselves, and we can't wait until society catches up to the science because it's a matter of life and death.
USDA, I've read their mission is to expand markets for agricultural products. But at the same time, they're coming out with the dietary guidelines. Is that one of the challenges you have in the States?
The USDA has an inherent conflict of interest. The U.S. Department of Agriculture, look, the same thing happened here in Great Britain. Right there was the Ministry of Food and Forestry, right? And then the mad cow debacle came, and they basically dissolved the department, right? Put food safety in charge of, medical professionals in charge of food safety instead of agricultural professionals. Same conflict of interest exists in the States. U.S. Department of Agriculture has this dual mission to promote agricultural products. That's what they're there for. But also, we put them in charge of food safety, meat inspections, helping to come up with the nutrition guidelines. So when it comes to eat more messaging, the message is clear. Eat more fruits and vegetables. There it is, right there in black and white in the dietary guidelines. But what about eat less messaging? Then there's a conflict. So what do you get? Instead of eat less meat, eggs, dairy, junk, what do they say? Eat less saturated and trans fatty acids, things like that. Biochemical components, right? Because they don't want to mention foods because that's too politically unpalatable.
but they'll mention vegetables, they'll mention fruits.
Well, they'll mention fruits and vegetables because it's an eat more messaging. Everybody's happy. Promote agricultural products and promote health. If they can do it without undermining the profit motive, they'd be happy to make the American public healthier.
Can you just explain a little bit about how corrupt the medical industry is in the US? It's kind of related to what you talked about already.
Well, there's a number of barriers for doctors. So you say, okay, we understand why some of the mainstream medical associations are sucking up to industry because they're being sponsored by Big Pharma, for example. But why aren't individual doctors speaking out? Well, there's a severe nutrition deficiency in doctors in education. We just weren't taught this in medical school, so we graduate without these powerful tools in our medical toolbox. We just weren't taught how to teach people to take better care of themselves, right? But of course, there's other barriers. There's lack of time, lack of reimbursement. Doctors aren't paid to tell people how to take better care of themselves. And also, there's much of medical education, both during medical school and postgraduate medical education, is paid for by the drug industry. I mean, the number one reason people go to their doctor in North America is what are called blood pressure checks. And they keep going to get their blood pressure checked so they can tweak the blood pressure medications. And so that's a boon not only to Big Pharma, which sell these chronic disease drugs that people take every single day for the rest of their lives because they're not actually treating the cause of their disease, right? Because they're not actually changing their diet. So they need to be treated every day for the rest of their life. So it's the boon to the Big Pharma, but also that's where the doctor's getting their next BMW from and sending their kids to college. I mean, it's the bread and butter of the GPs, of the primary care docs, is these blood pressure checks, which wouldn't be necessary if they didn't have high blood pressure. The number one killer risk factor in the world, 9 million people die of high blood pressure, a disease that need not occur if people ate plant-based diet, something we've known since the 1920s.
Questions 37 to 42. You will hear a plastic surgeon called Norma Woolston giving a presentation about surgical treatment for a condition called Dupuytren's contracture. You now have 90 seconds to read questions 37 to 42. Norma Woolston, and I'm talking today about surgery for a condition called Dupuytren's contracture, with a particular reference to a case I treated recently. Dupuytren was first described by a French physician of that name in 1834. It's a condition in which one finger becomes increasingly bent in a flexed position. The first sign is a formation of small hard nodules in the palm of the hand, but early diagnosis is relatively unusual because there is no associated discomfort. In its early stages, the condition may respond to steroid injections and physical therapy, but this doesn't necessarily halt its progression. The affected finger often becomes increasingly bent and can no longer be straightened. But patients tend to present with the condition only when manual dexterity is compromised, by which time surgical intervention is indicated. My patient, let's call him Eric, presented with quite an advanced case of Dupuytren's affecting the little finger of his right hand, a relatively common site for the condition, although a physical examination revealed that he was also developing the first signs in the thumb on the same hand. Eric was then a 61-year-old office worker who used a keyboard regularly. There isn't very much published so far on the causes of the condition or what might exacerbate the symptoms, but the digital age doesn't appear to have resulted in an exponential rise in the number of cases reported. Eric was finding the condition inconvenient and uncomfortable rather than painful. It was becoming tricky shaking hands with people, and holding a pencil was becoming a challenge. Eric didn't recall any family history of Dupuytren's. That's not unusual, but doesn't in itself mean that there was none. Indeed, we know that the condition is often present across the generations of one family. But because patients don't typically develop symptoms until late middle age or later, it often goes undiagnosed or doesn't develop to the point where it requires treatment. Indeed, mild symptoms are often attributed to mild arthritis or the general effects of aging and wear and tear. Nor did Eric report any of the other associated risk factors, such as smoking, diabetes, or low body mass index. It's worth noting, however, that he was of classic Northern European appearance, tall and fair-skinned, and Dupuytren's is known to be much more common amongst Northern Europeans than in other populations. In Eric's case, the condition had progressed to the point where surgery was indicated. It was clear to me that what was required was a fasciotomy to straighten the finger. Eric had some misgivings about this, as he'd heard about less invasive treatment options. But I explained to him that, taking into account the extent of development of the diseased tissue and the specific site, this was the only option, and he agreed to go ahead with the procedure. Fortunately, Eric was generally in good health, was taking no medications for other conditions, and had no concerns or negative history relating to general anaesthetic. This was much the preferred option because, although the surgery isn't lengthy, usually between 30 and 40 minutes, it does call for a complete immobilization of the hand. After the procedure, Eric was using a sling and pillows at night to hold the wound site high up and so prevent a build-up of fluids. I'd explained that wearing a sling when out and about also provides a degree of general protection. It's a remarkably effective way of signalling to other people to keep their distance, as the hand is very sensitive to knocks. But actually, he'd taken plenty of time off work, so this hadn't been a problem for him. Indeed, when I saw Eric at the follow-up appointment, the wound was healing well. His note showed, however, that the sutures hadn't all fully dissolved after surgery, and that this had been a source of discomfort. Worried that perhaps there was an infection, he'd consulted a nurse, who'd removed them and also taken the opportunity to excise some excess scar tissue, which had formed at the site. I reassured him that this was by no means unusual and wasn't a cause for concern. I was pleased to see that when he returned for the final consultation, Eric's wound had generally healed well. As is the case with many Dupuytren's patients, however, Eric volunteered that, despite my careful explanation at our first consultation about the treatment and recuperation period, he'd entirely underestimated the impact of the surgery on his daily life and how long the disruption would continue. That said, his finger is now much straighter. This treatment for Dupuytren's never completely straightens the finger, nor restores full use, but he'd been aware of that from the outset and had no complaints on that score. So far, apart from the initial indications in his thumb, there is no sign of recurrence, although this is relatively common, especially over time. I reflected, however, that perhaps being very familiar with the condition and having performed this kind of surgery many times, I hadn't made it clear enough to Eric exactly what to expect after the surgery. What Eric's case made me realise is that